Hello, my name is Gary Schneider, and I am an epidemiologist with 25 years experience. Full disclaimer, I am not an infectious disease nor an outbreak epidemiologist. However, because of what I do, I have been receiving many questions regarding the COVID-19 situation, and I've decided to prepare some informational videos with the hope that it will help people better understand our new reality in the wake of COVID-19. Another disclaimer, I have assembled this on my own. Therefore, any opinions I present are mine and not necessarily shared by my current employer. So my goal is to provide you with a general background of what we know in terms of COVID-19 and its impact within the United States. What I am presenting is in no way comprehensive. My focus is largely on helping you better understand some of the surveillance that is commonly reported in the popular media. Specifically, I'll be focusing on surveillance from the Center of Disease Control COVID response team that was recently published in MMWR and data from New York City Health. I will also refer to similar surveillance reports from other countries, specifically China and Italy. All of these surveillance reports have some inherent bias. Again, this list is in no way comprehensive, but some of the bias that we should be aware of is that related to the lack of testing, and that is going to impact the ability to test from region to region. And almost certainly within every region, there is a situation where individuals with severe disease are preferentially tested. This may cause issues with variations in denominator information, and almost certainly there are more infected people than people who are confirmed to have COVID-19. There is also lag time bias here. We're just talking about delay between symptom onset and outcomes. This could lead to an underestimation of rates. This is particularly true for mortality, which I'll talk about some later in the presentation. There's epidemiological confounding here. We're talking about factors that may impact outcome rates that are not fully accounted for, such as patient demographics and comorbid conditions, which we will talk about some, and other issues such as healthcare disparities and personal behaviors, an example of which would be smoking, is not addressed at all in the early surveillance reports that I'll be talking about. Lastly, information bias is here we're talking about differences in how outcomes can be attributed to COVID-19. A great example is if you have a patient with COVID-19 and some other underlying conditions, and they end up being hospitalized, is that hospitalization attributed to COVID-19 or is it attributed to their underlying conditions? Focusing on US surveillance, the first thing I want to do is talk about how to interpret the graphs. My graphs are, although they come from different reports, I am I have assembled the graphs in such a way that they are pretty consistent from report to report, even though that may not be how it was initially presented within the report. So what we're going to see is you're going to have percents on the left-hand axis, counts on the right-hand axis, and categories, in this case age group, on the bottom or x-axis. So if we were to focus in on this 20 to 44 age group, what we would say is that among the 2,449 patients with COVID-19, approximately 700, you look at the gray bar, go over to the right axis, approximately 700 were in the 20 to 44 year age group, representing approximately 29%. Now we're looking at the red line, represented approximately 29% of those infected. And the 29% you go over to the left-hand axis. So anyhow, this is from that early surveillance report, which was Published online on March 18th. It used data as of Monday, March 16th. It is currently the morning of Wednesday, April 1st. So it is approximately 2 weeks ago that this surveillance came out. And the first thing I want to point out is that at that point, just over 2 weeks ago, there were less than 2,500 reported COVID-19 cases to the Center of Disease Control. I believe as of right now, we are at about 185,000 cases in the United States. This report got some attention in the popular press because it was the first report showing that younger people were, in fact, impacted by COVID-19. Prior to this, the belief was that it was predominantly impacting older people, but what we could see here is that is not the case. Older people, as we'll see, may have more severe outcomes, but COVID-19 is impacting everybody. And we could see that the young adults in this early surveillance data were, in fact, the most impacted age group. Moving on to New York City, here we're looking at data as of 2 days ago. We had, at that point in New York City, there were approximately 36,000 cases of COVID-19. And at that point, that represented about 22.5% of the 160,000 COVID-19 patients in the United States. So big change, big jump in numbers in only 2 weeks, which we all know from watching the news. What we would say here, let's focus in on this young adult age group. What we would say is that among the 36,000 patients with COVID-19, approximately 15,000 were in the 18 to 44 year age group, representing approximately 42% of those infected. And again, you could put similar language around each age group. Here I am overlaying the information from that earlier surveillance, the CDC surveillance from 2 weeks ago with the more recent New York City surveillance. And again, remember that the CDC surveillance got a lot of attention in the media because of younger adults being impacted. And we see that's even more true in the New York City data. I want to point out a couple things here. The age groups of these younger age groups are slightly different. In MMWR, they use 20 years as a cutoff. In New York City, they're using 18 years as a cutoff. Likewise, at MMWR, this represented 2 separate age groups. I had to combine it into one larger age group. Similar for the oldest age group, this was 2 separate age groups, and I had to combine it into one larger age group in order to overlay data from both reports on the same graph. Now we are moving to hospitalization. Again, we're looking at the early surveillance data from the CDC, from that data as of March 16th. And what we would say here, let me just point out that the red line is a best case scenario. The green line is a worst case scenario. I'm not going to get into the details, but essentially they use different denominator information because they were not quite sure what the best denominator was at that point in time. What we would say here is that among the 508 hospitalized patients with COVID-19, again, we're focusing on this young adult age group, approximately 100 were in the 20 to 44 year age group. And that represented between 14 and 20% of all infected people in that age group. And again, we could put similar language with each age group. The key point here, though, is that you, regardless of the best or worst case scenario, you could see that there is a general increase in hospitalization rate with increasing age. For the red line, the overall average here across all age groups was 20.7%. Similar data from the more recent New York City hospitalization. Here we would say that among the 7,400 patients that were hospitalized with COVID-19, approximately 1,500 were in the 18 to 44 year age group, and that is representing approximately 10% of the individuals, 10% of the 15,000 people in that age group. So here, the gray line is representing the overall average, and again, that is 20.5%, very, very similar to what we saw in the earlier surveillance from the CDC, which was 20.7%. And we could see that this is also 10%. The hospitalization rate is also 10% in the youngest age group, and then it goes up pretty linearly as we move on to older age groups. Overlaying the earlier MMWR data, surveillance data with the New York City data, we see that the story really did not change that much. I do want to point out, though, some things with these younger age groups. Remember this MMWR, that early surveillance data, got a lot of attention because younger adults were being impacted, which was true. The good news is that although the estimate of the hospitalization rate among those people was between 14 and 19%. In actuality, in at least New York City, we're seeing 10%. So that's good news. Unfortunately, good news comes with bad news, and the bad news is the pediatric population. The early surveillance data suggested that the hospitalization rate was approximately 2%, and there we're also seeing 10%. So at least in New York City, we are seeing a higher hospitalization rate among pediatric patients than we would have estimated based on the early surveillance data. And you could see that for the older age groups, what we're seeing in New York City is right in the middle between the best and worst case scenarios from that earlier surveillance data. Here we are looking at ICU data. So again, just putting language behind this, I'm going to focus in on this 65 to 74 year age group. We would say that among the 121 patients with COVID-19 related intensive care unit admissions, 33 were in the 65 to 74 year age group, representing between 8 and 19% of those infected in that age group. Again, the 8 and 19% represents the best and worst case scenarios using the different denominator information. And again, you could put similar language with any of the age groups. Again, the key point is that we see that generally speaking, the ICU admission rate is increasing with increasing age. Focusing in on the best case scenario, the red line, that represents 4.9% of all infected patients and 24% of all hospitalized patients. Now, New York City is not presenting the ICU data in their reports, but there is some information from New York State. In New York State, as of a few days ago on March 27th, the ICU admission rate represented 3.5% of all infected people and 24% of all hospitalized people. And this, at that point in time on March 27th, just for reference sake, there were nearly 45,000 COVID-19 infected people in New York State. So again, the early surveillance data is doing a pretty good job of estimating what we're seeing 2 weeks later with much higher counts. Moving on to mortality or to case fatality rates, the early surveillance data had, from 2 weeks ago, had 44 individuals who died from COVID-19. Again, we have the best and worst case scenarios. And again, we could see that regardless of the best or worst case scenario, we could see that it increases with increasing age group. I didn't state it, but you saw that the overall average across all age groups there was 1.8%. Moving to New York City, similar story, increasing with increase in age group. The gray line is the overall average. Here, the overall average across all age groups is 2.2%. Overlaying the information from MMWR, we could see that in terms of case fatality rates, we could see that what we're seeing in New York City as of 2 days ago, and with 790 COVID-19 related deaths, is essentially at the midpoint between the early surveillance that had 44 COVID-19 related deaths that was from 2 weeks ago. I do want to point out, however, that this would have been a very different story as recently as March 25th. I actually originally put this graph together on March 25th, and what you could see is that the thick red line, what we were seeing in New York City at that point in time, almost perfectly tracked with the best case scenario from the earlier CDC surveillance report. And the overall average at this point in time, the gray line, was at 1.3%. So in just 5 days, this picture went from this to that. The overall average went from 1.3% to 2.2%. And I believe the reason for this is the lag time bias that I spoke about at the beginning. Quite simply, as of March 25th, people were sick but had not yet died. By March 30th, that has started to catch up. So that is an example of the lag time bias, that basically people need to go, that we don't have all the outcomes until people resolve from COVID-19 or succumb to COVID-19. Some information on COVID-19 outside of the United States. Here is the age distribution for China. Not a lot going on in the young age groups. Likewise, not a lot in the older age groups. There does seem that most of the COVID-19 patients are middle-aged adults with perhaps a tendency for some older adults, but not quite elderly. In Italy, we see a much different situation. In Italy, we see that the majority of the patients impacted by COVID-19 are in the older age groups compared to the middle age groups, and there are very few in the younger age groups. I want to point this out. I needed to back calculate these numbers. They were not specifically given. They reported mortality, and based on that, I was able to back calculate these numbers. Fortunately, at this point in time, with 22,500 cases in Italy, there was no reported mortality in the youngest age groups. Therefore, I really was not able to calculate those. So what that means is that this is really a 0 to 29-year age group. I honestly don't know what was going on there. I was unable to back calculate that. Looking at the age group from the 3 regions together, we can see that there are 3 different age distributions. In China, in the upper left, in 2018, the overall median age in China was 37.4 years. And I'm pointing that out because in Italy, at the same point in time, it was a much different story. The overall median age in Italy in 2018 was more than 8 years older, 45.5 years. So the difference in the age distribution that we're seeing is not unexpected. Italy has an older population, therefore it's not expected that we see more older people being impacted by COVID-19. In New York City, the age in New York City, again in 2018, the median age was slightly younger than it was in China. It was about a half a year younger, 36.9 years of age. Moving on to mortality. In China, again, very similar to what we saw in New York City, it increases with increasing age. The average across all age groups at this point in time was 2.3%. And at this point in time, there were at the point at which this was published, there were just over 1,000 case fatalities in China. Similar graph for Italy. Again, it's based on about 1,600 case fatalities. Remember, in Italy, the average age, or I should say the median age, is much older. And as a result, the average case fatality rate across all age groups is much higher. This gray line represents 7.2%. Look at it, all the case fatality information together, we could see that generally a similar story. However, I want to point out that remember that this gray line here was at 2.2%, but that just in 5 days, that gray line, the overall case fatality rate increased from 1.3 to 2.2% between March 25th and March 30th. If we were to go to the Johns Hopkins dashboard, we would see that as of a couple days ago, that the overall case fatality rate in China is 4%. Remember, this surveillance report was reporting 2.3%. So again, that lag time bias, as more people move through the process of COVID-19, the case fatality rate is moving up. In Italy, similar story. 7.2% is what was reported in the surveillance. If we go to the Johns Hopkins dashboard, as of 2 days ago, it's actually 11.4%. I'm pointing that out. Again, it's the lag time bias, or at least I believe it's the lag time bias. So just something to be aware of. Quickly going to talk about some comorbidity profiles. Here, what we would say, again, I'm just going to put English to this. What we would say here is that among the 1,121 patient fatalities in China, focus on cardiovascular disease, 92 had underlying cardiovascular disease, representing 10.5% of the 873 patients with underlying cardiovascular disease. And again, just like everything else, we could put similar language to each category. Obviously, now the categories are underlying conditions or comorbidities. But key point, what we see is regardless of the underlying condition, we could see that the case fatality rates are higher if you have an underlying condition than if you have no reported underlying condition, or if the data was just right out missing. I just want to point out, though, that here there was missing information on more than half. Only 12% reported an underlying comorbidity. So there is almost certainly underreporting in underlying conditions in China. In Italy, they did things a little bit different. So let's move over to Italy. Remember here, there were about 22,000 patients, 22,500, I believe, in this surveillance report. They did a detailed medical chart review on 355 of those patients. So what we would do, let's focus in on diabetes. What we would say is that among the 355 COVID-19 patient fatalities, 126 had diabetes, representing 35.5% of the 355 patient fatalities. So again, here they did things differently. They just focused in on 355 patients that were case fatalities and looked at underlying conditions. Again, you can see for each listed underlying condition, you could put similar language around it. I want to focus in on the right hand, though, right-hand side of this graph, because what we would say here, if we go to here, no comorbidities, what we would say is that among the 355 COVID-19 patient fatalities, 3 had no underlying conditions, representing less than 1% of the 355 patient fatalities. By contrast, if we go to 3 or more comorbidities, we would say that 172 had 3 or more underlying conditions, representing nearly 50% of the 355 fatalities. And you could see for individuals that had either 1 or 2 comorbidities that this represents approximately, each of those represent approximately 25% of the 355 patient fatalities. So the key point here is we keep hearing that comorbidity, people with underlying conditions have worse outcomes, and you can really see it here. The sicker the people are, the more likely they are to die from COVID-19. Last slide is New York City mortality, and looking at the comorbidities. Now here in New York City, once again, they did things a little different. The red line is the case fatality rate across age groups that we had already talked about. The purple lines are, the purple bars represent the proportion of people in each age group that had at least one underlying condition reported, and the underlying conditions reported are listed down at the bottom here. So in the 0 to 17-year age group, I have the numbers in each. There was one case fatality in New York City in the 0 to 17-year age group. That child had at least one of these underlying conditions. You could see that for each of the other age groups between 75 and, again, for these percents, the purple bars, we're looking at the right-hand axis. And for each of the adult age groups, we could see that between 75 and 80% of people who were case fatalities had at least one of these underlying conditions. So in summary, the reality in the US seems to be tracking between the best and worst case scenarios from the early US-based surveillance. This is important because we're going to be seeing more and more surveillance, and it's important to realize that generally speaking, the early surveillance does do a pretty good job. It's not perfect, but it does do a pretty good job. We should take it seriously. The trends in the US seemingly differ from those in other countries. We're seeing more young adults infected. And in the United States, the case fatality rate appears to be more similar to China than Italy. However, remember, it's increasing, and that's because of that lag between the disease onset and fatality. And we looked at comorbid conditions in 3 regions in 3 different ways. Regardless of how you look at it, underlying medical conditions are associated with a higher case fatality rate. Again, that is highly reported in the popular press, and there is no evidence to suggest otherwise. As I said, I am going to try to put together additional videos. So I have a few in the works. One is flattening the curve, where we are going to look at social distancing, flatten the curve, and all the things that we are hearing about on a daily basis. I have that one close to ready to go. However, as recently as last night in the White House press briefing, they presented some information on that, and I want to integrate that in to help people better understand what was presented in that White House press briefing. I already have the research, that the modeling that they presented. I have that paper downloaded. I have read it. I just need to incorporate it into those slides and record it. I also have a lot of people asking me questions about children. I'm a parent of 3 children. Parents want to know how this impacts children, and there is becoming more and more information available on that. So I will get into the surveillance in the pediatric population in a separate video. And I may get into more information on underlying conditions. We touched on it today, but as of yesterday, the CDC released another MMWR report that gets into much more detail. I honestly have not really looked at it yet. I read the abstract, but I will look at that, and most likely I will update the information on underlying conditions. That is it. I hope this was helpful. Please stay safe, stay healthy, and maintain your social distancing. It is important. Thank you very much.